Hello, I'm Nick Pyrsopoulos. I'm a gastroenterologist and transplant hepatologist at Rutgers, New Jersey Medical School, and I'm glad to be a part of the 6th annual Digestive Disease New Advances in Philadelphia. And this is a national meeting, and excellent topics were discussed today. I'm accompanied by
Stephen Brant. I'm the Chief of Gastroenterology at Robert Wood Johnson Medical School, the sister medical school to New Jersey Medical School. And my area of expertise is inflammatory bowel disease. Let's talk about what's new in liver diseases. I'm particularly interested in what is the role of the microbiome in liver disease. We hear about the microbiome maybe being important in inflammatory bowel disease, but does it play a role in liver diseases?
Absolutely. This is one of the hottest topics nowadays. And besides the fact that there are different liver diseases, such as fatty liver disease, where the change of the microbiome plays a cardinal role in driving an inflammatory component and inducing fatty liver disease, there is another area that people are looking currently now, and this is the population of patients with cirrhosis. The third area is the alcoholic liver disease. As we know, the change of the microbiome in patients who consume a significant amount of alcohol leads to leaky gut. In other words, the integrity of the intestinal mucosa is not optimal, and along different kinds of germs, particles of the microbes are transferred through the portal vein into the liver and stimulate an inflammatory cytokine with different kinds of cytokines and ultimately induces fibrogenesis. Another component is that patients with altered microbiome tend to develop hepatic encephalopathy in a higher degree than people that the microbiome in cirrhosis has maintained as in healthy patients, and this is something we need to take under consideration. The third component that people are looking closely, as we discussed earlier, is fatty liver disease. Apparently, obesity and the consumption of high-fat diets and potentially high-sugar diets can lead into a leaky gut situation as well. And for some of the population with a metabolic syndrome, including diabetes, dyslipidemia, or genetic predisposition, as you know, there are some genes, characteristically the PNLAP3, the patatin kinase, can induce actually fatty liver disease and can lead into NASH, non-alcohol-induced steatohepatitis, and fibrosis. Another component that this can lead as well, we see that this is very often, and looking at our transplant list nowadays, you see that there is a change in the composition. Alcoholic liver disease and patients with fatty liver disease have surpassed patients with viral hepatitis. Mm-hmm. So it is very important, and I truly believe that as the years are passing by, we will see more and more coming from this aspect.
So are we defining specific microbes that are responsible for why someone with obesity may develop fatty liver diseases, whereas other people that are even more obese will not develop fatty liver disease?
Yes, absolutely. And we're looking closely because we know that there is a certain type of microbes that people can have as healthy. And now through some sophisticated techniques like the 16S, looking at the ribosomes, we're able to identify the shift and correlate with different kinds of disease. This is true. Another important component besides the microbiome is the probiotics and the prebiotics as well that people are looking into as well. Mm-hmm. So it has been reported that having a certain probiotic population and try to feed them appropriately with prebiotics, for example, nuts, they can maintain a healthier microbiota. In other words, our diet, along with genetic predisposition, environmental factors, and of course insulin resistance and lack of exercise, is formulating now a different pattern and a different kind of liver disease that we see nowadays.
So one day we might be able to feed a specific diet to get the right kind of microbes growing, or give the right kind of microbes in order to prevent or ameliorate potential fatty liver disease.
Sure, this is true.
I've read that there's been some new advances in primary biliary cholangitis, and I know that's an area of interest of yours. Can you expound on that?
Absolutely, and now we know that besides the ursodeoxycholic acid, that has been associated with a decline in the rate of fibrosis if it is given early. There is a certain population, actually it can be 30 to 40%, that does not respond to treatment with ursodeoxycholic acid. And there is a new medication with an M-obeticholic acid, which is a farnesoid receptor agonist 100 times more potent than ursodeoxycholic acid, that can be utilized in patients that didn't respond to treatment or patients that couldn't tolerate treatment. This has been associated with a significant decline of the biochemical pattern, such as the alkaline phosphatase and the GGT, and potentially slowing down significantly the fibrosis component. Sometimes this kind of medication can induce adverse events, such as pruritus, and we know that patients with primary biliary cholangitis come with pruritus as per definition, so sometimes might not be tolerated very well. But I'm really enthusiastic about this field because there are some new compounds on trials. These are the PPAR alphas along with gamma or delta action, and they are currently on trials, such as the sarogliptazar, or some other FXRs that appear to be very potent with very encouraging results so far.
The PPAR gammas, if I remember correctly, are being used for treatment of diabetes, is that correct?
This is correct, and depending on the action of the compound, sometimes can have a pretty good effect on bile acids as well.
I see. Are we at the point of using these medications in clinical trials?
There are some different compounds that are already on trials, and we're waiting for the results.